Hi there, my name is Dr. Kate Margalit. I've recently branched off to start Jewel Veterinary Surgery, which is a concierge mobile surgery service that delivers specialty surgery to your veterinary hospital. Sharpening your surgical fundamentals is really a deep dive into all of the preparatory steps that sometimes we tend to gloss over. This is very important and will help reduce complications and hopefully help educate you and your staff. If you have any questions, don't hesitate to reach out to me. Sharpening your surgical fundamentals. This is really important, and I can't stress this enough. Standardize all your protocols. I promise that putting the work in the front end will save you work later. It will help all your staff with consistency. It will have all of your information and SOPs already formed to ease onboarding of new staff, because all your staff will already be doing the same thing. It will improve efficiency in your hospital. And, always our goal is to reduce the risk of mistakes. So having less morbidity and mortality in your practice really should be our number one priority. And I always say that it's better to work smarter and not harder. I'm hoping that since you're here online that you had an interest in this, but I've done this lecture several times and I've heard all these things. Why am I listening to this? Listen, if you have never had a problem, call me. I want whatever water you're drinking, whatever you're taking, because if you do enough surgery, it is part of the job that you're going to have complications, and you want to keep those to an absolute minimum. But I don't know any surgeon that's never had a single complication. Some of the things that we're going to talk about, you may say, this is really expensive. This is out of the scope of what our practice can do. But there's so many things that either cost nothing. It just, change sometimes can be hard, but doesn't mean that it will cost your practice anything, or it's just a really nominal cost. And it may actually be cost saving if you really evaluate what you're spending currently. Now, this is really common. We're burning the candle on both ends. We're exhausted. Well, delegate some of these SOPs, involve your staff, empower them to help you, and involve them to create protocols that are great for your clinic. And I already do this, boring. Well, you're a good sport and you can fast forward the things that you already know because this is on YouTube. So let's go into prep, scrub, and drape. Remember, this is important, that infections do originate not only during the process of surgery, but also during the entire period before and after the surgical event. So all of those things can influence your outcome. And that starts with patient preparation. Clipper care is so very important, and I think we underestimate the importance of clipper care. Clipping or shaving in advance will allow for bacterial proliferation. So we don't want to shave, like if you're bringing in an orthopedist to your practice, the week before, you don't want to shave that thinking you're going to save time, because really what you're doing is going to increase risk of razor burn and increase the likelihood that there's going to be infection at the surgical site. And there's been documentation that can occur. Clipper burn honestly can sometimes be more painful than the surgery itself. And so keep in mind that when you are shaving a patient, no matter how complex the surgery is on the inside of your patient, the client, all they see is that shave job and your incision. And so it is a complete representation of the quality that you are trying to let your client know that you did on the inside. And it is representing your quality of work. Cleaning and lubricating the blades are really important. Some staff don't actually know the difference between the cleaner and the lubricant, and I see them used interchangeably and inappropriately. So clipper side is what you use to clean the blade with. Cool lube is what you're utilizing to cool the blade in the process of clipping the animal, because a hot blade is going to damage the skin. And before you start shaving, you want to make sure that the blade has been adequately cleaned with clipper side. You want to check the blade for any missing teeth, because that can really cut and drag the skin. And then while you're clipping, you want to cool the blade adequately. And these clippers actually come with an instruction manual that I read the first time recently as I've acquired my own clippers. And there also is a lubricating oil that you're supposed to apply daily to your clippers. Okay, so have an SOP to maintain those. So here's just an example of clipping for a TPLO. And sometimes these little short-haired dogs, it can be a bear to shave them because their hair is going in all different directions. So really pay attention to the direction of the hairline and go directly with the hair or against the hair. And you may need to change directions and pay attention to the heat that is being generated from the blade. It's usually the areas kind of over the joints and in the axilla and inguinal area that tend to take the most beating. And so you want to have extra caution when you're moving forward and avoid this kind of razor burn, because that makes clients very unhappy and dogs very painful. The other thing I need to talk about, and is so common, most folks won't shave wide enough. Remember, the hair all kind of grows back at the same time. So set yourself up for success. I know your spay incision may be very small, but what happens if you have bleeding and you have to extend your incision and you did not shave high enough? If you are going into an abdomen, even if you're making an incision that is tiny initially, you should have the option to expand that incision all the way up to the xiphoid. And so the finger that's there is pointing to where the xiphoid is in both the dog on the left and the cat on the right. And the picture on the right was actually a re-explore that I had to do. I don't remember the circumstance of that cat, but it was sent over, and there was some emergency that was significant that the practitioner didn't feel comfortable with and wanted it referred. And that area where that's clipped was as much as it was shaved. And you can see the difference of when I'm exploring that belly to how much I'm shaving to give myself room to work. Set yourself up for success. Be able to extend your incisions easily. Always shave an entire belly for whatever abdominal procedure you're doing. I don't care if it's a spay, I don't care if it's a foreign body, I don't care if it's a gastropexy. Every abdominal clip should look the same. Don't underestimate how much you need to shave, because mass removals and wounds, you will get burned. If you think that you've shaved wide enough for a mass removal, go around one more time with a full clipper length, because once you take that mass off and you pull that skin together, I promise you'll start seeing hair. And so you have to account for the fact that when you pull that skin together, you're going to lose some of that sterile field. And so you really want to overestimate so that you don't contaminate your site when you're closing. And so always shave more. As long as the shave job looks neat, I promise the client will not care. We also want to remove hair. So if you have a shop vac, a vacuum system built into your hospital, I do suggest that you will clean the tip of that vacuum with some alcohol to make sure that there's just not a lot of dirt and accumulation that's there. If you don't have a shop vac, then you can buy one really cheap. I have a clinic that has one of those Ryobi ones that they probably got at Home Depot, or you can get a cheap one on Amazon. But if you don't have one in a pinch, you can just use a lint roller until you get one. Antiseptics are going to prevent or reduce the growth or action of pathogenic organisms and living tissues. They're going to prevent infection. We use them on a daily basis with surgery, and there's 3 major ones that we utilize. So alcohols, or 70% isopropyl alcohol, the mode of action that causes protein denaturation, lysis, and metabolic interruption of cells. The thing that you need to remember about alcohol is that there's just a rapid kill. And so when you use alcohol, it kills a lot of stuff, which is great, especially on your patient and your hands, but there's then no residual activity. Okay, so when it gets on there, it does its job, but it's not going to do anything else after it dries. You want to avoid contact in eyes and mouth in your patients and yourselves. The next thing that is commonly used in practice is iodine. So povidone, iodine, similarly, the method of action, oxidation, substitution by free iodine denatures proteins. Do you need to remember that? Not as important as remembering that it has an intermediate onset of action with some residual activity. So when you apply iodine, it helps you out later on, but it takes a little bit longer to work. So using that as a sole antiseptic is not as beneficial. It can be used in the eyes. So an ophthalmologist, if that's their go-to scrub, I use it for both eyes, ears, and it's fine to use in the mouth. It can be used in a diluted sense and for wound care. I tend to go towards the next antiseptic, chlorhexidine, or just use saline for wound care, just because if you have a large wound, in theory, if you absorb a large amount of iodine that gets systemically, that could be a risk. There's no resistance that's been identified with iodine, so that's kind of nice. In general, if you're going to do it with large wounds, you want to do 0.1%, but I wouldn't do huge cavitated kind of wounds, maybe just a small wound. It does become inactive where there's blood and organic debris. So you have to kind of do a cleaning of the skin. Putting this on dirty skin and expecting it to do the job isn't going to work. So you kind of have to get the initial dirt off an animal for this to be effective. So chlorhexidine, very commonly used in practice. Now, surgical scrub solutions are the 2 to 4%. Disinfectant solutions are the 0.5 to 2%. And then for wound treatment, you want to make a solution that's less than or equal to 0.05%. Otherwise, that's toxic to fibroblasts. So measure that. So it's, I believe it's 25 mils to a liter. Don't just make it, quote unquote, a light blue color if you're putting it in an actual open wound. Make a real accurate measurement because you don't want to cause any toxicity to the cells that are trying to foster healing. Okay, so similarly, mode of action disrupts cell membranes. Like iodine has a moderate onset of action. Now, the benefit of Chlorhex is that it has excellent residual activity. So once you put it on, it's going to do some work for a while. You do want to avoid it with ears and eyes because it can be toxic to the inner ear and the cornea, and in theory to any sort of neurotissue. So this is what I give clinics. This is my little formula for rough scrub preparation. Every surgeon might have a little variation, but you're welcome to use that. My go-to is going to be Chlorhex mixed with distilled water and then alcohol for anything that's appropriate. And then there's just a list of exceptions. When you are doing a rough prep, you always want to, initially get all the organic debris or dirt off your patient first, and then start and scrub from where your incision is going to go and move your way out. Either move in a circle or find some way to go in opposite directions so that you're really never going back over the area where you start. You do always want to wear gloves when you're handling a patient. Vigorous scrubbing can cause loss of the natural epithelial barrier, so just don't get aggressive. Sterile prep. I like to do a rough prep that is not sterile, but still wearing non-sterile gloves, but we should always do a sterile prep on all of our patients. That involves utilizing sterile gloves, and you can decide how you want to do your sterile prep. Now, if you want to do sterile gauze, you have a couple options. There's pre-packaged sterile gauze, or you can autoclave in metal bowls if you're trying to avoid having all this pre-packaged gauze, or you can use a alcohol-based product that I think is ideal, and that is DuraPrep or ChlorPrep. Either an alcohol-based iodophore, which is DuraPrep, or an alcohol-based chlorhexidine product. And that seems to have greater efficacy to the aqueous solutions where you would just be doing a sterile version of your rough prep. And it is a one-step process, which is nice. So this is going back to this kitty cat. Essentially, you saturate the sponge by clicking the top of the applicator, and then this lovely technician is working her way around from the center of the surgical site all the way to the outside, and you're painting it on, and you can actually see where you've been, which is quite nice. The disadvantage is that it does certainly add a big expense. So if you're doing something like a spay or a minor procedure, this may not be cost effective for your practice, but every single patient of mine does get this kind of prep. Hand hygiene is very, very important. We definitely need to be conscious of washing our hands in between patients. It is super important to help reduce hospital-acquired infections. I do think that we can utilize just a nice neutral soap and do that as part of your scrub protocol, and may replace using scrub brushes in certain circumstances depending on what you'd like to do. I have started to have a blended scrub method, which I'll talk about in a later slide, but hand washing is always the first step. If you're washing in between patients, at least you want to do that 15-second twinkle, twinkle, little star type situation. If you're washing before a surgical prep, especially for your first wash of the day, then you want to wash for 1 solid minute and thoroughly dry your hands. Do we do the rub or the scrub? So aqueous solutions like iodine and chlorhexidine are out there. I have developed a topical allergy to chlorhexidine scrub, so I cannot utilize that. So I have to scrub with iodine, but if you can do either, chlorhexidine is more effective. And that goes back to our earlier slide. I talk about the improved or increased residual activity of chlorhexidine over iodine. And if you are scrubbing, you want to scrub a minimum of 3 minutes, a maximum of 5. There is some emergence of resistance to chlorhexidine in some hospital environments to staff, so keep that in mind as well. Alcohol-based hand rubs are really what you should be using as your final prep. Whether you're scrubbing with a brush, washing your hands, you want to do an alcohol-based rub. It will help reduce skin dryness and redness, and both of these products have some emollients, so your hands just don't get cut up like just using straight alcohol. Shorter rub time versus a scrub time, 1.5 minutes is typically what I will do versus having to sit at a sink for 5 minutes. Now, Sterilium is a single agent alcohol scrub. It's 85%. The FDA requirement is to reduce resident skin flora prior to the surgical procedures, and Sterilium was the one that obtained that within 90 seconds of application time with that alcohol alone. Now, Avogard only has 61%, and so they had to add 1% chlorhexidine to meet the FDA requirements for whatever level of bacteria they needed to kill. They're both completely fine. So whatever you want to use and whatever you prefer is great, as long as you use one of them. I prefer Sterilium. Avogard just, for me, kind of feels, I don't like the way it makes my skin feel after utilizing it over and over and over again. The consideration is to do what's called a blended approach. So maybe your first scrub of the day, just because animals can be a little bit dirtier than humans and we get all this organic debris on us if we're not wearing gloves. So maybe the first scrub of the day with the nail pick, you do more of a traditional sponge, and then subsequent cases, if you're going straight from case to case to case, then you don't need to do anything but do the alcohol-based rub between. But if you're stopping and doing things like eating lunch or using the restroom, maybe then at that point you want to do your minute hand wash with neutral soap, dry your hands adequately, and then move into your rub. This Clean Hand Saves Lives came out of my vet surgery text, and it's just showing you the typical spots that people often miss on that bottom right. And this may be something that is useful for you to print out to remind staff the protocol of what to do. And it can go in your new SOP book, because that's really helpful for all of your staff. I really highly recommend that you treat your operating room like an operating room. There shouldn't be anything in your operating room that is not needed for surgery and surgery alone. And ideally, there's nothing on a table that's going to collect dust. Your operating room should have things put away in a cabinet or drawer and should otherwise be empty when not in use, except for the monitoring equipment, your table for your patient, and your instrument table. Caps and masks should be worn for all staff. It's ideal if you maintain that when you enter the operating room, even without a patient, but for sure, when there is a patient there or there is open sterile equipment, that caps and masks must be required for all staff. Limiting foot traffic will also limit the amount of things that get dragged into your OR. And then keeping your cool OR temperature is very important. OR's temperatures can get very hot, and that's what breeds bacteria, also makes your surgeon sweat. But I recommend keeping your OR temperature between 65 to 68 degrees to try to really minimize the risk of infection and avoid cords and tripping hazards, not only for your staff safety, because the last thing you want is for your staff to get hurt, but also for prevention of your staff tripping into your surgical site. So I had the pleasure of working with a human scrub nurse that now has moved into the veterinary field, and she was amazing, and she insisted on gloving and gowning me, and I had no idea what to do. Like, I felt like I was in an episode of Grey's Anatomy, but I just could not figure out how to have her help me. But I felt very, very pampered when she allowed me to do that. So that may not be something that you get on a daily basis. Either way, you do want to gown. Gowning and gloving serves as a major barrier between sterile and unsterile areas. And the biggest thing is that they decrease the bacterial load in the operating room. Many practices are still using the reusable woven fabric gowns. I ask you to reconsider this because here is what we know. Bacteria will penetrate those gowns in 30 minutes. So you are definitely increasing the risk of bacterial load that can go to your patient. And are you actively saving money? I would like you to think about that potential question, because when you have these reusable gowns, you have to wash them. So that takes time, that takes water. You have to then take them out and roll them because you don't want any hair. Then you have to wrap them. That takes materials. Then you have to put them in your autoclave. That also costs money. And so by the time you do that and you're paying a technician an hourly fee to get that done, are you actually saving money, or are you spending more money than if you use something that is better for the patient? So this is what my gown costs today. I get a gown that's just shy of $3. And so do you think that you're actually spending more money processing a gown that might increase more bacteria in your operating site? I bet you if you calculated it, you are. And so just think about it. It will also make your life so much easier, and you'll have extra. You won't run out, because if you only have a couple gowns and all of a sudden you have to go back into surgery, you'll have that backup in the box where you'll have those sterile gowns. At least consider using them for a procedure that might take more than 10 or 20 minutes. So drape also is probably one of the most inexpensive parts of your surgery. So these rolls of drape are $1 per yard. I ask you to consider to fully cover your patient or any instrument table with drape, because what I see a lot is these tiny little packs that are open with a small amount of drape, and then you're surrounded by all this non-sterile field on your instrument table, and then also between your patient and that instrument table. So there are so many opportunities for sterilization to be breached and for your surgical site to be contaminated. So why not set yourself up for success? And there's just so many benefits. I do like Mayo stand covers. Many of you use the small Mayo stands. I like the Mayo stand covers because, when you apply them sterilely and you put the Mayo stand cover over, it's also sterile on the bottom of that table, so you can slide that into your patient. And if you have a bigger drape over your patient and then you slide that Mayo stand right over you, then there's really not a whole lot of working room where your instruments go and the patient goes, and you're much less likely to contaminate the surgical site. I get those for 62 cents a piece. Easy breezy. But, if you're cutting drape and wrapping drape, just add a little bit more. It's really cheap. Just set yourself up for success. It also keeps your patient warm. Now, you can purchase pre-made larger table drapes in packs if you're doing more extensive surgeries than spays and neuters. So a patient drape, this is a super basic pack that just has a 4/4 drape, a large patient drape, and some gauze. My packs are a little bit more involved just because it's easier for everything to be packed together. There's a variety of packs that are already in existence that certain companies can offer you, or you can create your own custom packs. And it's just really nice to have the whole table drape there and see all the things that you need all in one pack. It just also saves time. This just shows you how to open these packs. Sometimes different companies put them in different orientations, but it's always good to have a video or teach your staff how to open one without it being directly related to a surgery, so they feel comfortable opening it for you sterilely when you do need it. This goes back to having a large sterile field here. I like a continuous drape. So if you have a bigger OR table and you're doing a belly or a chest or something like that, I like to take the patient drape all the way up onto the table so that there is no gap of non-sterility between the patient and the table. So let's just say my Cautery pen sort of falls in that little fold. That's totally sterile and I don't have to worry about that. And it also, like I said, has the benefit of keeping the patient a little bit warmer. Radiopaque gauze. I'm hoping that everybody uses this in practice. The term for a gauze that's left in a patient is a gauzy peboma. Gauzy Gauze is Latin for cotton, and boma in Swahili, it means a place of concealment. Little cocktail party fun fact for you. And there's not a ton of information out there because, let's be honest, most people either don't know or really don't want to shout it from the rooftops that they left gauze in their patient. But what has been documented is that most of the actual problems that we see arise from spays. And you may say, it's never happened to me, but here's the thing. How can you be sure? Because it takes time to form granulomas or adhesions. It's not going to happen overnight. It could be years later where you're no longer at that practice, where those patients are no longer seeing your hospital, or they've moved away. It's so hard to actually have accurate reporting. Here's what I do know. Leaving a gauze in a patient is 100% preventable. The reported cases, what could happen? What happens if I leave a gauze in there? You can get infection, or even infection all the way up to the bone, osteomyelitis. You can get draining tracts and fistulas. It can cause bowel obstruction. There have been cases that show it can result in need for body wall reconstruction. It can transform to cancer, and death has been reported. I don't think that I want to be responsible for any of those things just because I didn't take that one extra step. And when you look at the small literature that's out there, the most common reasons that it occurs, probably the number one reason, is just lack of surveillance. So you're either not using radiopaque gauze, you are not counting or recording, you're not using a checklist with your staff, and some people just don't even know that that's a thing. So now you can't say that you're not aware. So let's have surveillance in your hospital. So here is the nitty-gritty cost. The cost to me for a box of radiopaque gauze is 83 cents. So to me, that seems worth preventing these horrible signs. The cost to count costs you absolutely nothing. These 2x2 gauze, do not use those in surgery because those can get lost very easily in a belly. I have had cases where I have left gauze in an abdomen. However, those patients were still under anesthesia because I had radiopaque gauze and I had a surveillance checklist and a counting system with my techs. So we count before and we count after. So when we don't get the right count, I'm gonna go back and look. And I can tell you that I am very fastidious about making sure that there is no gauze that winds up anywhere near a body cavity. But sometimes when you have a little bit more of a chaotic situation, or you have other people scrubbed in with you, maybe you have a student, maybe you have a new vet, you cannot control everything. And if you think that you will never leave a gauze in a patient, I promise you there is a very good chance that it could happen because I've seen it. So count. That costs you nothing. I would suggest if you have any open body cavity surgery, at a minimum, you are using radiopaque gauze and lap sponge and counting. And I promise you it will save you some heartache and stress. I'm going to get off my soapbox and let's go into heat support. So this little heat support diagram on the left, I also provide that as part of my sort of check sheets for clients. You're welcome to use this. This is what I like to use for heat support: bear huggers, circulating water blankets, fluid line warmers, blankets, hot dogs. We do not want to ever apply rice bags, heating pads, or warm fluid bags to the patient because you will see burns like demonstrated on the right, and you may not see it when you send the patient home because it takes time for the skin to declare itself, and you may see something that comes back a week later and say, well, that wasn't because of what we did in surgery. And I can guarantee you that if it looks like that, then that was a burn. It's avoidable. And so use good technique. Heat support is essential for your patient. Just make sure that you're using things that are safe. So improving visibility is something that I talk to at almost every general practice that I go to, with almost every student, intern, resident. And I also sometimes have to lecture myself because when I'm sitting there and I'm in a dark hole or I'm setting myself up for failure, I have to sometimes step back and say, okay, let's redirect, let's make this smart. If I can't see what I'm doing, then that's where mistakes occur. And the number one thing that I recommend is to make your incision longer. And how do you prepare from having to make an incision longer? don't forget to have a large enough clip. Okay, that just goes back to what I was saying in the beginning. But other things that can aid you are having good lighting. Suction greatly improves your visibility. Having good control of your hemostasis also greatly improves visibility. A pool of blood does not let you see anything. And then using some very simple tools to aid you. Retractors are key. They're my favorite things in the world. Use things to help you work smarter, not harder. So incisional length. In a laparotomy, you should always be thinking going xiphoid to pubis. And sometimes you have to get back more caudally if you need to get back towards the bladder. Now, listen, if you're doing a cystotomy, I admit I do not do a full explore for a cystotomy. But if you are doing an exploratory surgery, then for a foreign body, for a cancer, for whatever it is, you should be exploring the entire abdomen. Do not be tunnel visioned. You will never learn what is abnormal and what is normal if you do not look and you do not feel. And it's not just kind of throwing your hands up there and feeling like, oh, that feels okay. You have to see, right? And so your incision should go from xiphoid, parapreputially if it's a male, and get close to the pubis, okay? And have a list in your head. If you have to write it out one day as an exercise, go from the diaphragm all the way back to the pelvic area and say, what should I be seeing? What should I be feeling from even the smallest parts? And if I'm ever at your practice and you want to scrub in and work through what that list might be, I will run through and explore with you to help you anytime. You have to get used to seeing what's normal. It's the same thing that you learned your first week of vet school, that learning to do a physical exam from nose to tail, starting and thinking about doing 100 normal dogs so that you understand, your first year of vet school before you can start feeling abnormal things, so you know what the difference is. You have to train your eyes and train your hands. And so really, really don't have tunnel vision. If you do not look, you do not find. Lighting is equally as important. You want to use your operating room lights. If you don't have sterile light handles, then adjust where your light should be in a sensible way before you start your surgery and before you scrub in. Have your techs adjust the lights for you. And there are disposable light handles that I use in every practice that are extremely affordable, or you can purchase reusable ones that you can sterilize. Those are all options. If your lights are not great and you don't want to right now invest in hooking your practice up with newer, brighter lights, then get a headlamp. That works out well. There are some great affordable surgical headlamps. And in the interim, when you're just trying to figure out what you want, you could probably order a pretty simple one from Amazon as well. And if you're really struggling with light, get your tech and shine a flashlight or your phone light in an area where you need some illumination for specific things. There are options when you are struggling for visibility, but always think about the light before you start. Suction is just one of the most useful things that you can have in practice. It's a very small investment. I really like this suction device. If you are building a practice, having suction integrated into your ceiling or where your gas exchange goes, your scavenger, is a really nice add-on. You can just plug into it. But if you want to have a portable suction device, this one's worked really well for me. It's quiet, which I like. But you can probably find a really inexpensive suction device, even off of eBay, just to have in the interim, and that will greatly improve your visibility and have better isolation of your hemorrhage. Helps to remove contamination. The old adage, solution to pollution is dilution. You want to flush out your bellies. And sometimes dogs will regurgitate at the time of surgery when you have an airway secured. Being able to suction out their airway, being able to preemptively suction any airways if you're doing any airway evaluation, things like that can be very, very, very useful. Hemostasis. Your blood clot formation takes a few minutes. The first 30 seconds, your platelets are going to aggregate or clump, and then it's going to be stabilized with your fibrin matrix within 2 to 3 minutes. There are a variety of hemostatic agents. In veterinary medicine, the ones that are readily available to us are mechanical hemostatic agents, which I'm going to go into on the next slide. Active hemostatic agents are things that kind of stimulate the normal process of hemostasis, and that mainly is thrombin. It's just really cost prohibitive. So it's not something that most vets have access to. And then there are hemostatic sealants, and if you want to get really fancy, they are not using the patient's hemostatic mechanisms. It's basically like a biologic glue. So I think, vascular surgeons and neurosurgeons and humans will use that, and it seems really cool, but it's probably really expensive, and I don't have any knowledge or experience related to that. But I do use a lot of mechanical hemostatic agents. There's a whole lot of different ones out on the market, like the gelatins, which are the gel foams, and the vet spuns, that's on the bottom right and middle there. Collagens, Surgicels, and oxidized cellulose. There's bone wax. I use that a lot for more neurosurgery. And then kind of polysaccharide spheres like Hemoblock or Bleedex. And lately, my go-to hemostatic agent is Vetigel. I've only used it a couple of times, but my friend was involved in some of the clinical research associated with that. And it is a sodium alginate and polyacetyl D-glucosamine. But when I talked to the rep, it's basically a food-grade mushroom kelp with water. And so it forms a hydrogel rapidly and kind of adheres to the wound site. It basically kind of plugs the hole and even provides some level of compression at the capillary level. So this was a dog that had epistaxis, and it has these little applicators there. It's going up the nose. And there we go. It stopped that pretty well. And then this one to the right is a knee, and there was a small popliteal artery bleed. In a big dog, that can be pretty devastating, and I don't think a squirt of that is going to make it completely stop. But if you've gotten it down and you can add this definitely will help you back there. It is a one-time sterile application, but if you use the syringe sterilely and you had some left over, the rep did relay to me that if you keep it refrigerated, then it lasts for about a week for non-sterile application. So that's where you could put it up the nose or use it for like a tongue laceration or a pad laceration where you just need a little bit more hemostasis. When you apply it, if you're using it in that week period, you do want to warm it up to room temperature before application. In general, this is absorbed in about 4 weeks. You don't want to leave it in an enucleation site, though. If you're using it, you want to scoop it out, which is not hard to do. I used it with an enucleation recently, but most sites you can leave it there and it will be absorbed in 4 weeks. I think, gel foam, I'm not sure how long that takes to resorb. I feel like that takes forever. So something like this makes me feel a little bit better. Cautery. So monopolar cautery is just an excellent tool to have in your arsenal. Typically, most cautery units will have a cut and coagulate function, and some pens even have a fancy blend function. The flow of current comes from the generator when active to the electrode, which is your handpiece, then flows through the patient to the ground plate, which is your inactive electrode, before returning to the generator. So it's part of a circuit. And the small area of that handpiece concentrates that current. And so that increases the temperature of that contact tissue, and that's what causes the coagulation. It will coagulate vessels that are less than or equal to 2 millimeters in size, and large plate contact is really important. The problem is if there's not adequate contact, then there can be alternative paths to the ground, aka you'll get cautery burns. And so some things to be helpful to avoid those are to put the ground plate as close to your surgical site. So if you're doing an abdominal explorer, let's not put that ground plate up by the chest. Okay. You also want to use a ton of conduction gel. I like to put conduction gel and then I do a water or saline soap lap sponge over it to really spread that conduction gel well. There are a variety of plates that are available. This sort of standard metal plate is probably only used in vet medicine. They don't use that in human medicine. They have some safer plates. There are some disposable ones that you would shave and actually have great contact because you're now going directly to the non-haired skin. And then there are some other great options out there as well if you want to invest for your practice to try to minimize the likelihood of having an alternative path to that ground plate. So here's an example where we're utilizing the cutting function to go into the skin incision. And then once you get through the skin, you can use the coagulation function. I do want to mention that in the slide beforehand, the settings on the generic picture of the Bovie are absolutely not the settings that I would utilize. So I typically will set my cautery somewhere between 15 to 20 and adjust based on what I'm doing and the delicate nature of what I like to do. Bipolar cautery is also an option where you can purchase bipolar handpieces in the foot pedal. And this Bovie device, I love bipolar cautery. I don't currently have it on mobile because most of the surgeries I utilize it for aren't generally surgeries that I do on mobile, but I love it for really delicate, fine things, tiny patients, neurosurgery, things like that. You can use bipolar cautery for anything. It's just, it takes a lot longer to get through tissues because your current is getting delivered just from tip to tip. So you don't have any risk of having cautery burns. It's just a much smaller focal area that you're delivering the current to. And then this is just showing you on the Bovie how you would toggle between bipolar cautery and monopolar cautery if you choose to have that. Vessel sealing devices are a great add-on. More and more general practitioners are seeing the value of having these. I do have a vessel sealing device. I've used several different kinds. There's lots of them that are out there. I personally have the Voyant just because it is lighter and easy to transport. I love the Force Triad ligature. That's what I have used in multiple practices. It's just a bit heavy, but if you are not transporting it from place to place, it's a really nice add-on because you also have the benefit of having a built-in cautery unit. That particular company, you'll have to use the disposable cautery pads, but you can get several uses out of them if you kind of play your cards right. This one is the Cayman Asculop. This one is the Force Triad ligature, and this one is the Voyant. And there is another vessel sealing device on the market. I personally have not used it. I have a colleague that has it. It's the MV1 Mano Medical. It has monopolar, bipolar, and vessel sealing device capabilities. I think the benefit of that is that it has autoclavable handpieces where all these other sealing devices that I talked to you about need to have their handpieces either gassed or in plasma. I'm not a huge fan of the concept of that particular model only because those handpieces, they don't have the ability to cut at the same time that they seal. And for my purposes, that's just not what I need it for. But for a general practitioner, I think that's a great place to start. And I've heard that maybe they are making new handpieces that have blades that can come out, but I think I would need to see that and utilize and see how I feel about that. But it is something to think about and an option to explore if you don't want to have to invest in plasma and have gas in your practice. How they work essentially is vessel sealing devices denature collagen and elastin from the vessel wall by applying pressure and bipolar energy. And if you remember, the monopolar cautery only seals vessels that are less than or equal to 2 millimeters in size, where the vessel sealing devices use that energy and can seal up to 7 millimeters in size. And that's quite large. In people, the ligature handpieces are produced for single uses now in humans, and there is a hack to be able to do multi-use, but you have to then purchase a special piece to do that. So just be aware if that's something that you have to invest in, you also will need to do a little bit of a workaround. I have to give my favorite piece of equipment some diligence here, some due diligence. Balfour retractors. They will be so helpful to you in practice. They are very affordable. They are workhorses. They will last forever as long as you don't lose the pieces. They are the most underutilized piece of equipment that I have seen in general practice when doing explorers. And I will tell you, if you don't love your Balfour, it's probably because you're not making an incision that's big enough, and that means that you're not seeing anything. So this is how you would use a Balfour. You can place some wet lap sponges, moistened with saline to protect the surrounding tissue. That also kind of provides a little bit of a workspace for you to bring organs. Like if you're running the bowel through, they can then gently sit on that lap sponge without touching skin directly. And that's a Balfour spoon that's being used to help retract the cranial aspect of the incision by the xiphoid. And you can see that it really holds things open so that you can have better visibility. It comes in a variety of sizes. I have small, medium, and large. It's great. You really can't go wrong. I'm so grateful that you took the time to open your mind and consider learning something new or refreshing something old. If you're in the upstate area or Western North Carolina region or surrounding regions and you'd like me to come and help you with a mobile case, please feel free to use this link for referral. And if I have not visited your practice and you would like to arrange a practice visit, I would love to come. Please just shoot me an email and I can't wait to come visit you. I hope you have a wonderful day. Take care.